Hello, my name is Kemi Dole, and I appreciate the invitation to speak today on clinicians' role in access to equitable cancer care. This is our lane. When I was in training, I trained at arguably one of the most beautiful women's hospitals in the country. It was state of the art. And very much the feeling behind this building when it was going up was that if you build it, they will come. If we build the most wonderful state-of-the-art facility, we will be able to give the most highest quality and equitable care. I thought the same thing, and I envisioned myself within these walls caring for women all over, regardless of context, to the best ability that medicine could give. What I learned, though, in taking care of a particular patient, a Black woman with endometrial cancer who was dying alone in the middle of the night, was that despite her beautiful room and the beautiful view and everything that we had to offer within the walls of the hospital, our warm, welcoming, and comfortable environment was necessary, but it was never going to be sufficient to account for the marginalization and inequities that she had experienced even before coming for care. This reality is difficult for clinicians. In so many ways, we are socialized into our roles in society as powerful, as autonomous, definitely as very capable of dealing with problems, some of the most difficult problems people will face. And more recently, the term heroes has been used commonly to describe the role of clinicians in people's lives. What's difficult, though, and what's true, is that we are simply a piece of the puzzle. And in the case of equitable cancer care, we are a piece of an interlocking system, structural system of inequity, of which health systems and services are just one structure. And this reality of clinicians operating in a society of interlocking, inequitable structural systems is really at odds with that dominant clinician identity that we have of powerful, autonomous, and capable. This really comes to light in an anecdote that I want to share from a clinician who presented an amazing body of work using patient-reported outcomes, really listening to patients in order to measure their treatment success and make decisions about their care. I asked a fairly simple question about how this tool accounted for other elements in patients' lives, things like food insecurity, things like being remote from any kind of access to care, and other issues that face marginalized populations. And his response was one I will not forget. If there's no food in their fridge, there's nothing I can do about that. And I want to offer that though this was difficult to hear at the time, it is not unusual, whether it's spoken or something internally stated. These kinds of responses, I can't imagine changing the system. How am I supposed to help? There's nothing I can do, happen when you have a dominant identity of somebody powerful and autonomous coming up with such a difficult system of interlocking structural inequity. It's a power that ends up being combined with a learned helplessness, which unfortunately leads us to avoidance. And at this stage, what I want to talk about is how we can move out of a place of avoiding the aspects of our patients' care, the inequitable factors that they deal with that influence their outcomes, and into a place of action. This kind of avoidance is what leads us to statistics like these, that Black women with endometrial cancer have an over 90% higher 5-year mortality after diagnosis than white women. And this disparity is only increasing with, until very recently, very little national movement for change. We avoid. My personal story is that these statistics and my patient encounters led me to co-found Econo, the Endometrial Cancer Action Network for African Americans. We focus on community support, education of the public and of providers, as well as research consultations. But this jump was not an easy one. And I want to talk about the steps that I think all clinicians can go through to move from avoidance and into action. Econo's work has resulted in the sister study, which is a national study of social support interventions, deliberately thinking outside of our clinical box of how we can intervene to support people going through treatment, because we understand that their larger environment and their social settings have in some ways more impact on the outcomes we care so much about than the particular chemotherapy or the particular treatment they're receiving. So here are my offerings of steps to take to move past avoidance and inaction from the clinician point of view. First, we need to unlock our curiosity. We need to ask our patients about their social determinants of health, about social isolation and other risk factors. We need to move with the same kind of curiosity. With that level of curiosity, we need to then move with courage to execute personalized care processes. When we understand and accept that we are part of an interlocking, structurally inequitable system, we then understand that people who enter into that system, we must change standards. We must go around normal processes in order to account for various marginalized positions to deliver equitable care. And that does require courage. Oftentimes we might be going against the grain, but it's worth it. And the reason why is that because we're clinicians and because we have the positions of power that we do, and we would go the extra mile and adapt care processes to meet the needs of our patients, we have a unique position in order to advocate, to make a commitment to go beyond the one-on-one patient and advocate for hospital-based policies that would allow us to no longer have to change the standard because the standard adapts to be fair to everyone. We can also move into researching community-driven solutions that we know are much more likely to be effective, as well as be received well by communities to improve their health. Ultimately, we make a commitment because we understand that being a clinician is so much more than being a powerful, autonomous, capable hero. It's asking and answering the question, who are we to the communities we serve? I want to take a moment to note that courage and commitment that I'm calling for, they thrive in an environment of meaningful support. And when we ask clinicians to make these locally based cancer care interventions, we need to support them with emphasis on these kinds of actions from professional societies, on creating more clear vertical career paths, with equity work being seen as a viable and valuable career pathway, as well as making sure our national funding priorities include locally based clinical interventions that are changing the lives of patients every day. I leave you with the fact that certainly access to equitable care is our lane as clinicians. If we can unlock our curiosity, move with courage, and make a commitment, we absolutely can make a difference. Thank you very much.